The importance of establishing a core outcome set for endodontic clinical trials and outcome studies by Karim et al. In 2022 from Queen's University. We all know that the goal of endodontic therapy is to prevent or treat apical periodontitis. The success and failure of this approach are referred to as treatment outcome and is reported either by the patient or by the clinician during clinical examination and special investigations. The reporting of endodontic treatment outcome are evolving from purely clinician-focused to patient and disease-focused outcomes. However, outcome reporting in endodontics is blighted and disoriented by constantly changing definitions and a lack of a standardized criteria for measuring outcome in clinical studies. This has been recognized as a major cause for heterogeneity in outcome reports and the lack of consensus in the definition. This has a damaging implication in evidence synthesis, clinical guideline development, and ultimately for patient care. An outcome is defined as a change in patient status over time, whereas an outcome measure is a tool or test used to assess patient status over time, and it should have a high quality evidence for good content validity, internal consistency, and feasibility. Traditionally, endodontic treatment outcomes are defined as success or failure, but differing definition of success and failure has resulted in a wide variability in reporting endodontic treatment outcomes. Strindberg, 1956, in his landmark study on endodontic outcome assessment, he established criteria for the evaluation of endodontic outcome, commonly referred to as Strindberg criteria. Using these criteria, success is defined as absence of symptoms and normal radiographic appearance of the periapical tissue, where presence of symptoms or radiographic changes is considered treatment failure. The Strindberg criteria, however, were regarded as inflexible, and an alternative classification taking into account patient comfort and function was suggested. However, these early classification systems were considered not to reflect the dynamics of endodontic disease, and requests were made for a switch from treatment-specific outcome and moving into disease and patient-specific outcomes. Another classification reintroduced by Friedman in 2004 in their classification, which defined outcome as healed, healing, disease, and functional retention. Functional retention or survival is considered a positive outcome and referred to as asymptomatic normal clinical presentation with or without radiographic evidence of periapical radiolucency. The concept of functional retention as an outcome was reintroduced in the light of the high success rate of implants and changes in treatment planning dynamics, which was approved by the American Association of Endodontics in 2005. Further modification of outcome criteria were introduced, such as stringent and lenient by Friedman 2002, strict and loose by Eng in 2011. However, they were all based on two-dimension radiographic assessment. The debate and controversies in defining endodontic treatment outcomes are ongoing. Other more recent suggestions proposed that the term success and failure be replaced with effective and ineffective treatment. For the types of endodontic treatment outcomes and outcome measures, it is considered as clinician or patient-reported. Clinician-reported outcomes are interpretation of data obtained from detailed history taken along with clinical and radiographic examination, and considered not standardized or validated, such as a history of pain and painful response to percussion and palpation, which is considered crucial outcomes that have been used in recent endodontic treatment outcomes studies. However, it could be carried out differently among clinicians. Assessment of pulp vitality could also be considered as clinician-reported outcomes. However, they are associated with varying sensitivity and specificity, and currently there is no test that can be objectively determine the status of dental pulp and degree of inflammation. The principal clinician-reported outcomes that is used when deciding if the endodontic treatment was successful or failure is radiographic evidence of healing and progression of the disease. Conventional radiographic examination is the most used measure to assess the periapical status of the tooth, but for some time reports have suggested lack of robust correlation between histological and radiographic finding after root canal treatment. The introduction of a more sensitive imaging technique such as CBCT may provide details that are not available from conventional radiographs. However, recent reports showed that the diagnostic accuracy of CBCT was reduced with root-filled compared with non-root-filled teeth with small periapical radiolucency, in which CBCT was shown to overestimate the prevalence of inflammation in root-filled teeth. For these reasons and the risk of increased radiation doses means that the use of CBCT may be unjustifiable, at least for routine assessment of the effect of treatment. For the patient-reported outcomes, they are directly reported by the patient via self-reported questionnaires without interpretation of the patient's response to treatment by a clinician or anyone else, and pertain to the patient's health, quality of life, or functional status associated with health care or treatment. In the European Society of Endodontics level guidelines, tooth survival was considered as the most critical outcome, where pain, tenderness, and swelling were critical outcomes. An important outcome was oral health-related quality of life. It is worth noting that oral health-related quality of life is generally considered the most important dental patient-reported outcomes due to its direct relationship with the impact on patients for many years. Patient-reported outcomes have traditionally been attributed less importance than clinician-reported outcomes. For instance, a scoping review discovered 300 clinician-reported outcomes, but only 114 patient-reported outcomes published through the past 4 decades. However, over that period, there has been a decline in the number of reports of clinician-reported outcomes and a small but steady increase in the reports of patient-reported outcomes, such as pain and quality of life. For the outcome reporting, the need for a core outcome sets. It is evident from the recent scoping reviews that there is a significant heterogeneity and a lack of standardization in reporting the outcomes of endodontic treatment, as well as an absence of consensus as when and how these outcomes should be measured. This led to barrier to evidence synthesis, guideline development, and clinical decision-making, and it contributes to research waste. Recognition of these problems across many areas of health led to initiatives for the development of what are known as core outcome sets. It is defined as an agreed, standardized set of outcomes that should be included, measured, and reported as minimum in all trials or outcome studies in a particular field. Core outcome set should support outcome choices in clinical trials, routine clinical care, and systematic reviews. The benefits of core outcome set are not just limited to evidence synthesis, but most importantly, they can enhance the validity of studies by reducing heterogeneity and reporting bias in clinical trials. The development of core outcome set should start with identification of the scope and existing knowledge by carrying out a robust review of the literature. An important aspect of core outcome outcome set development is the involvement of various stakeholders, including patients, clinicians, and researchers, and policymakers, whose input will be important for the validity of the core outcome. The relevance of core outcome sets to endodontic clinical practice. Clinicians often rely on the results of randomized clinical trials and systematic reviews for evidence-based decision-making in their day-to-day practice. However, the applicability of research to clinical practice depends not only on the quality or the validity of the primary study, but on the consistency, relevance, and importance of the chosen outcome. Due to the fact that the clinical trials attempted to answer similar research questions but evaluated different outcomes, or the same outcome at different times or with different tools, it is difficult to combine the results of these clinical trials in systematic reviews and meta-analysis to assess the clinical practice. Similarly, when the researchers intend to measure outcomes that are of no or less relevance, even in well-designed trials, the translation of the findings to clinical practice becomes meaningless. The relevance of a clinical trial is directly related to its outcome, but most trials in dentistry are focused on outcomes that are important to the clinician but not to the patient. Therefore, development and uptake of a core outcome set, including outcomes that are important for patients, may change our traditional approach in assessing outcomes and success of endodontic treatment in research and ultimately clinical practice. In the end, there is lack of consensus in the reporting of outcomes of endodontic treatment. The negative impact of this on the evidence synthesis, guideline development, and clinical care has led to initiative to establish an endodontic core outcome set using validated methodology. This will improve the relevance and consistency of reported outcomes, promote efficient research synthesis, and reduce research waste. In addition, it will help the researchers to select the most important outcomes to be included in the clinical trials and how and when these outcomes should be measured.